Hi, welcome to JNO Network Open Live. I'm Seth Truger, Digital Media Editor for JNO Network Open.
And I'm Mike Berkowitz. I'm the digital media editor for JAMA and the JAMA Network.
So continuing our tradition of Canadian intensivists, we are talking about the assessment of therapeutic interventions and lung preventive ventilation in patients with moderate to severe acute respiratory distress syndrome, a systematic review and network meta-analysis. And we've got senior author Dr. Eddie Fan with us. Welcome, Dr. Fan.
Thanks for inviting me to join this chat.
Great. So why don't you tell our viewers a little bit about yourself and what you did here in the study?
Yeah, great. So I'm an adult critical care physician here in Toronto at the Toronto General Hospital. I'm also the medical director of our extracorporeal life support program, which is one of the interventions we investigated in our study. Our study was a systematic review and network meta-analysis, as you mentioned, looking at different interventions that are useful or could be useful in the management of patients with moderate to severe acute respiratory distress syndrome, or ARDS, which is a catastrophic form of respiratory failure. And the challenge, I think, for clinicians, and the question that we want to set out to answer, is that there have been many head-to-head trials of these different interventions compared to sort of best usual care, telling us what might be useful. But as patients worsen with their respiratory failure, it's not clear to clinicians which one of these interventions they should prioritize. So one of the things we want to answer with the network meta-analysis is that because none of these trials compared some of these interventions head to head, the network meta-analysis would give us the opportunity to say, well, we know that, for instance, prone positioning is useful compared to control, and we know that ECMO is useful compared to control. But if you have the choice between the two interventions, which one should clinicians do first? So we investigated 9 different interventions using 25 randomized controlled trials to create this network meta-analysis, and we have a graph of that, or figure of that network geometry in the paper, showing the different relationships between the interventions and the groups that were compared. And what we found was that amongst these 9 interventions that had been previously tested in classic or traditional randomized controlled trials, 2 interventions seemed to be significantly beneficial in terms of reducing mortality. And one was ventilation in the prone position, and the second was veno-venous extracorporeal membrane oxygenation, or VV ECMO. And then interestingly, again, to answer the question of which one should clinicians consider prioritizing if they had a choice of these interventions to use as patients were worsening and needed something to be done, we created a ranking of probabilities for success, if you will, or efficacy of these interventions. And what we found was that amongst the ranking for the best probability of being successful, VV ECMO ranked number 1, with prone positioning ranking just under that. There's no significant differences between these 2 rankings, but again, both of these supporting the idea that instituting these interventions early in patients with moderate or severe ARDS would be very useful.
Yeah, that's fascinating stuff. I mean, obviously, ARDS is a pretty serious disease. The mortality rate was about 35% of the patients in all these studies, which is quite a bit. You know, these are some of the sickest of the sickest patients. There's also not only do we have a lot of questions about these patients, but it's hard to study patients who are this sick, because a lot of times it's, these patients are getting kitchen sink approaches. It's hard to tease out what works. And also a lot of the interventions, as you're getting at, are pretty resource intensive, like VV ECMO and prone positioning. I mean, even just the logistics of getting a patient upside down and doing standard nursing. I've honestly never seen it in real life, but it just sounds fascinating.
Yeah. Well, I agree. Like, that's one of the advantages of doing the network meta-analysis. We're unlikely to, because exactly as you said, like, randomized trials are difficult, they're resource intensive, these interventions are costly and resource intensive. So getting some of these head-to-head comparisons are probably unlikely in the near future. So this methodology gives us a chance to answer some of these questions that might not likely otherwise be answered. And again, as you mentioned, because they are costly, resource intensive, and typically delivered in specialized centers, it's important, I think, for clinicians to have some of these answers so we can understand that when these things start to occur, you get these types of patients in your intensive care unit, what are the sorts of things we should prioritize, and what are the sorts of interventions we should try in a certain order before we progress to the more aggressive, costly, invasive, resource intensive interventions like prone positioning and veno-venous ECMO.
Right. Prone positioning is a real production in the ICU. It takes a team of people to reposition, and like all the normal workflow is completely disrupted in order to attend to a patient in the prone position. You know that, Dr. Fan, better than I do. It's been a while since I've seen it, but I remember it being not a small ordeal. But I imagine a little less expensive maybe than VV ECMO, although when you take into account staffing FTE, I don't know whether that's actually true.
Yeah, I think it's an excellent question. I don't know that it's been explicitly studied from a sort of cost or resource intensive point of view, but I often like to think of prone positioning as actually a low tech, low cost intervention, right? I think certainly if you think in lots of acute care hospitals, you might be already proning patients in your operating room on a daily basis to do certain operations and that sort of thing. Now, granted, those patients are typically more stable. They're undergoing maybe elective surgery, so it's different than a critically ill patient. But like many things in the ICU, it's exactly as you said. It's about teamwork and training. So in the original trial that showed the dramatic mortality benefit of prone positioning, there was a video accompanying that publication in the New England Journal of Medicine that showed the team approach to proning this patient that didn't require any special beds, any special equipment. It really just required a team of coordinated professionals flipping this patient into the prone positioning, recognizing that this was an extremely life-saving intervention. So what I would say is that there's certainly a bit of reticence and there are challenges with both putting the patient into the prone position and then caring for the patient in the prone position. But that once you have a protocol in place, you've done some maybe training runs on it, and you have a team available to perform it, it actually could be a very safe, and again, as the data tells us, a very efficacious intervention in these very ill patients.
And why is prone positioning efficacious? And who discovered that, if you have any idea?
Yeah, so this is actually an old intervention. It's actually not a new intervention. It's been studied probably for more than 20 years. It's really, I would say, like many things in medicine, the result of a team of researchers, clinicians, and whatnot, just making the discovery, but probably best attributed to Luciano Gattinoni, who's an Italian intensivist, and his team in Milan, who recognized early on from CT scanning that when you ventilate patients in the prone position, there's actually a more homogeneous distribution of ventilation. And our current understanding of how we might mitigate the complications and mortality from ARDS is that we want to prevent injury, which is really iatrogenic injury, from the ventilator and the things that we're doing in the ICU. So the patient needs positive pressure ventilation to live because they have hypoxemic respiratory failure. But we now understand that delivering ventilation to the injured lung can actually make things worse, cause injury to the lung, and that injury becomes a biological stress, and that biological stress becomes multi-organ failure, and multi-organ failure becomes death. So any strategy that limits the injury the ventilator delivers to the injured lung, we think leads to more benefits. And when you ventilate the patient in the prone position, actually there's a more homogeneous delivery of ventilation that leads to less iatrogenic injury to the lung, and we think that that's why it translates to improved mortality.
Yeah, and in my practice, we're not proning people. We do ECMO a bit, but probably not nearly as much as you do. But it's interesting seeing over the course of my career how much the lung protective ventilation has basically just caught fire and spread. When I was a med student, the default standard vent settings were 550 and 12, and now it's basically 400 to 450 and 16 to 18, and just it's taken some time. There's been the usual, I think, reluctance and clinical inertia, but it's just I think we're going to stop calling it lung protective ventilation soon. It's just going to be ventilation.
And those are tidal volumes and pressures, right?
Tidal volumes and rates.
And rates.
So basically, generally, lung protective ventilation is like a 6 to 8 milliliters per kilogram ideal body weight.
Right. So I wanted to follow up on that because if you look at your figure 2, it seems like most of your data are comparing lung protective ventilation to other interventions. Really, the bulk of the evidence, if I read that figure correctly, is there, not for VV ECMO or prone positioning. Those are only 1 to 2 trials with 17 to 400 participants. So I wonder if you could kind of talk about the implications of concluding that there's less evidence, that there's stronger or credible evidence for these two interventions, which are evaluated in fewer patients and fewer trials.
Understood. Yeah. So I think the important thing that's an important point to highlight for sure. So our comparator group for all of these interventions was lung protective ventilation. So just as you mentioned, we sort of consider that now the standard of care for these sorts of patients, so that we only included trials that use lung protective ventilation in both the intervention and the control groups, and then added a certain intervention such as prone positioning or ECMO. And you're absolutely right that the number of trials enrolling patients in these studies were limited. Prone positioning is an interesting one because actually there's been many, probably close to 10 randomized control trials over the 20 years that it's been studied. And it's really been an important lesson in understanding the physiology of prone positioning, which we've talked about a little bit, and then understanding the response of the patient to that intervention. And so over time, over the 20 years, the randomized trials that finally demonstrated the success honed in more on the sicker patients, a consistent signal in all the RCTs that the sickest subgroup of patients seem to be the ones that benefit, and milder forms of the disease did not benefit and might have accrued more complications. And then also understanding as the RCTs progressed was that the longer we left the patient in the prone position, the more the benefit. So over time, the earliest randomized controlled trials of prone positioning showed that short duration and all comers, no signal. But then when we got to the most recent trial, that focusing on the sickest subgroup of patients, so almost like a prognostic enrichment, and then proning them for up to 16 to 18 hours today led to this dramatic mortality benefit. So that sort of was a nice evolution in terms of the physiology, and then tailoring randomized control trials to respond to the physiology that we understood about the patient. For ECMO, it's been a bit different. So ECMO also is not a new technology. It's been around since the 70s. And really, it's exploded since the H1N1 pandemic because of, again, better understanding of the physiology, technological advancements in the provision of ECMO, probably just better general critical care as well. And that's only led to 2 modern trials of VV ECMO and ARDS, which we included in this study. The challenge is that, as we already talked about, these studies are extremely difficult to conduct. They're extremely resource intensive. The first trial in the UK took 9 years to complete. And the most recent trial that we completed, Eolia, took 6 years to complete. Okay. I think we're unlikely, based on the feasibility of these trials and the very limited population that study, are unlikely to have another randomized control trial conducted to answer this question. So these are the data, our network meta-analysis, a traditional meta-analysis, and a Bayesian reanalysis of the Eolia trial that was published in JAMA to help support the idea that VV ECMO may be useful in these patients.
And thanks for mentioning that you included a Bayesian meta-analysis. I wonder if you could tell viewers and listeners what that is, what that does, what that contributes to a conventional network meta-analysis, frequentist network meta-analysis.
Yeah, so a Bayesian analysis in general, whether it applies here to a meta-analysis or a Bayesian analysis of clinical trial data, I think is more useful in these sorts of settings, and hopefully will become more common because it better mimics what we as clinicians do at the bedside. Bayesian analysis takes what you understand, your prior knowledge, your prior beliefs, and that sort of thing, and then some kind of test or new data, which affects the likelihood, and you sort of multiply those things together to get a posterior or a post-test, post-intervention odds or probability of success. So here would be, say, we're calling success reduced mortality. So in a Bayesian network meta-analysis, we're making these comparisons, whether they're direct because they've been studied in previous trials, or indirect, they haven't been studied in previous trials. So we're taking the data that we have, we're adding the new data from the trials, from the new comparisons that we didn't have before, and that gives us a probability, which we've reported here as odds ratios, of the chance that that intervention will reduce mortality in that comparison. So it mimics what we do at the bedside. We take what we know, we do some kind of, say, diagnostic test, or we do an intervention, and then we get some kind of probability of success. And that's sort of why Bayesian analysis here is nice, because it sort of mimics what clinicians actually think and do on a daily basis.
Yeah,
great.
I always find that with Bayesian stats, it's the math gets really complicated. At the same time, it's both so complicated and so simple, because it's literally what we all do all the time. I think a thing, I find more information, I have updated thinking.
You have an updated probability or
Yeah.
likelihood. Although I think for some people it's a little too subjective or soft because it's
Well, the concept makes a lot of sense.
Absolutely.
The implementation
Yeah.
is.
Which isn't a criticism. I mean, I agree with Dr. Fan. We should probably be seeing it more in the journals. And JAMA published a prominent Bayesian reanalysis of a randomized trial because there continued to be controversy in the field over a cardiovascular intervention. That was in mid-2018. But it's always complicated for people to kind of get their arms around, so I wanted to address it.
Yeah, and the Eolia Bayesian reanalysis in JAMA, if I remember correctly, it was almost as much an article about Bayesian analysis as about lung protective or about ARDS. So great. So thanks for joining us. I think we're out of time for this segment. We're going to move on to the next paper. But this has been really fantastic. Keep up the good work.
Thanks for talking to us, and thanks for sending your paper to JAMA Network Open.
Appreciate it. Thanks very much.
Thank you.
Great. We've got a bunch of new people with us. Dr. Mamakai is back. Angela Priests. I'm going to mispronounce this, but Tsewal Tan, and of course Ketamine. Min, welcome back as well.
Min.
And now we're moving on to our next paper, the immediate antihypertensive treatment for patients with acute ischemic stroke with or without history of hypertension, a secondary analysis of the CATIS randomized clinical trial by Zhang and colleagues. So this is really interesting. This is a pre-planned secondary analysis. So they did this CATIS RCT where they randomized people to get early antihypertensive therapy or basically no blood pressure control in stroke.
And early means during the hospitalization.
Yeah, during the hospitalization, starting basically within the first 24 hours. Right. So not ED early. Our early is oftentimes hours, and it's always funny when we talk about early and stuff like that. It's like, well, that's not 24. But that's just different context, not right or wrong. And here they reanalyzed it. They did a secondary analysis where they looked at whether there was a difference in outcomes in patients based on whether or not they had blood pressure before. So basically, you have blood pressure.
Whether they had hypertension before.
Excuse me. Yeah, everyone has blood pressure before their stroke.
Correct.
Usually.
Right. One hopes.
Well, by definition. Yeah. So basically, you either have a history of hypertension or don't have a history of hypertension, have a stroke. You're randomized either way to get treated or not treated for blood pressure. They actually stopped everybody's blood pressure medications completely in the placebo or in the non-treatment arm, and then saw how patients did. You can see how they did in figure 2, how the blood pressure went. You can see everybody's blood pressure went down. There's something in the pathophysiology of stroke where patients' blood pressure does shoot up kind of acutely. It's something that's typical we find. And they found that everybody's blood pressure went lower. Patients who were treated were the lower lines. Their blood pressures went, not surprisingly, much lower. But patients with a history of hypertension overall had a little higher blood pressure than patients without a history of hypertension. Not surprising. There were about, 2,000 patients in each group, basically. And
to be clear, this is a trial that was performed in China.
Oh, yeah.
Right? It's a national trial. So that is neither here nor there, but in terms of representativeness and applications to populations.
Right. Absolutely. Good points. And then basically what they found is really no major difference. The biggest, most important things, death or major disability. They looked at the primary outcome was 14 days or hospital discharge, whichever I guess happened first. And then secondarily looked at 90-day outcomes. And I mean, their relative risks were basically 1 across the board. The visual abstract has them all up there. It's basically 1, 1.99, 1.01, 1, 1, 1. The only difference they found, and this is a secondary outcome, was the difference in 90-day recurrent stroke. And the patients who had a history of hypertension did better with blood pressure control with a relative risk of about 0.4, which is pretty good. There was a technically statistically insignificant, but probably signal towards benefit or towards harm in the patients without a history of hypertension. But also, these are 90-day recurrent strokes in patients who then didn't die or didn't have a major disability from that stroke. So obviously, I'd rather not have a stroke than have a stroke. But
after your first stroke.
But if I'm going to have another stroke, if I don't die and I don't have a disability, that's not so bad.
Right. What I was intrigued by was the apparent signal of harm for patients who got immediate antihypertensives who didn't have prior hypertension, right? Because those were not statistically significant, if I understand them correctly. They cross 1.0, but the bulk of the evidence around the confidence of the point estimates are greater than 1, and the bulk of the evidence is kind of to the right of 1.0, suggesting that we're actually hurting people who are not previously hypertensive who get immediate antihypertensive therapy during their hospitalizations.
Right. I think we talked about this on a previous paper months ago, where it seems, at least in my casual observation and my interactions with neurologists in stroke, is that there's this big kind of debate about the pathophysiology, about do we need to keep perfusing the brain and keep the blood pressure naturally up during
Right.
the stroke, and is
Right.
that is lowering the blood pressure taking oxygen away from the brain, or do we need to stop the deleterious effect of hypertension? So this is one more little piece of that puzzle that absolutely does not answer that question at all.
Right.
But I think gives us a couple more little slices towards where some more I don't know, right-sizing care.
Right, but to keep in mind, even though this was a pre-specified secondary analysis, this is essentially a subgroup analysis, hypertension, no hypertension. And though it comes from a randomized trial, they were not randomizing patients, I don't believe, on the basis of prior hypertension. So the randomization is off. So though this is valuable data, it is not at a level of evidence that's equivalent to RCT. But it does point in a certain direction in terms of clinical practice for blood pressure management in these patients.
Yep, absolutely. Yeah. So again, not practice changing, but hypothesis generating and filling us in some more information.
Right.
We got a couple new people joining us, Karen Keeley and Deanna Marie 208. Welcome.
Hey, welcome, guys.
And we'll move on to the table of contents rundown.
Let's do that. Let's run the list and see what else was in the journal.
A couple things today, some interesting stuff. This one is one I have to send to my parents. Association of Hearing Loss with Dementia.
What'd you say?
Yeah. You've been planning that all week, haven't you?
It just occurred to me.
Right. So this is from Taiwan's National Health Insurance Research Database, big database they take from the National Health Insurance System. You look from 1997 to 2013, basically found everybody who had an ICD code for hearing loss for more than 1 year based on 2 outpatient visits or 1 admission, and didn't have dementia, and then matched them with patients who didn't have any kind of hearing loss at all during the study period, and basically found which patients then accrued a diagnosis of dementia at 1 year after the diagnosis of hearing loss. Overall, 11% of patients develop dementia, and basically 60% to 40% ratio. So they calculate a hazard ratio of 1.17 when they do adjustments for comorbidities. So basically, essentially a 1 in 5 increased chance of developing dementia if you have hearing loss. I think this is one of those, this is an extra piece in a puzzle that we've been putting together for years, that when you have hearing, there is some link between hearing loss and dementia. It's plausible that some of it is like the cognitive burden of having to pay more attention to people all the time. You're straining your brain. You're kind of like, I don't know, maybe your brain atrophies because you don't hear what people say, so you stop paying attention to conversations.
Yeah, it seems to have face validity, although we don't know which direction, if it's causal or if there's a, mediating variables about social withdrawal, less stimulation, and things of that sort. We could speculate on that for a while. This is, I think, confirmatory. Other studies have shown this, and if you go to JAMA-OTO.com, JAMA Otolaryngology, one of the editor's choice articles there at the top of the page is a systematic review and meta-analysis of observational studies like this that show a similar association with an increased risk for dementia with hearing loss. What's nice about this is that it's from the Taiwan National Database, and those studies are really appealing because they have near 100% capture of an entire population. So for kind of population epidemiology, you almost can't beat that, except in maybe some Scandinavian countries where they do much the same thing. But it's really kind of a rigorous look at population epidemiology that kind of confirms what we think we know from other studies.
Right. And again, this is totally observational. We can't point, I can think of plausible reasons why this would, or why hearing loss could cause dementia, which this doesn't show. But it also, hearing is, basically nerve-based. Dementia is nerve-based. It might be that dementia causes hearing loss, or the same problem that causes both things is related. Who knows?
Who knows?
Yeah. Or it's all video games.
Okay, next.
So moving on, analysis of human performance deficiencies associated with surgical adverse events. So basically, what they did is these were authors from the Baylor College of Medicine in Houston. I get very confused by all the different Baylors in Texas because there's Baylor College of Medicine, Baylor College, and Baylor Hospital that are all different.
Okay.
Apparently, Baylor was a big deal. They looked at 5,400 operations, all types of different surgery, and analyzed 182 adverse events from their M&M series, and found that from their schema that they used to classify these adverse events, that 56% were basically human error, what they call human performance deficiencies. Interestingly, the average of the cases that were related to human error, the average error was, there was an average of 1.8 errors. So basically, oftentimes errors don't happen alone. It's the Swiss cheese model. It's not that one thing goes wrong, it's that multiple things go wrong, or something goes wrong, it's not caught, and then a second mistake happens, and that's what leads to harm.
And so is this surgeon error or is this team-based error? Do they get into that level of detail?
I don't remember that level of detail. I believe it's both. It's
Okay.
a lot. There were a couple of anecdotes that were interesting they talked about.
Yeah.
Yeah.
Talk anecdotes.
Yeah, one of them was interesting. One of them was a surgeon who was on a telephone call outside the operating room.
Okay.
They didn't. I didn't.
Better than inside the OR.
Right, but I don't know. But he was in the OR on the phone with somebody outside the OR.
I see.
So basically, the question is, was that distracting from an attention point of view? And there are lots of times where it's totally appropriate for a surgeon to be
Sure.
on the phone. If they
Talking
get
to
called,
PATH,
yeah,
right?
talking to PATH, talking to the SICU about another patient who's
Right.
decompensating or something like that, or has a surgical complication.
Right.
There's all sorts of reasons, but it's also fraught with peril.
Okay.
Another one was there was a stylus, a foreign body left inside a patient that the surgical team was pretty sure they saw in all the imaging, but radiology kept not seeing on the imaging, even though it was there. And these are the kind of stacks of errors where this is what I'm talking about, where
So they didn't believe their eyes; they believed the report.
right, and they kept saying like, "Don't we see this there?" Radiology, no, we don't see it there. And they go, "Okay, I guess it's not there."
Okay.
And, apparently leaving foreign bodies in people unintentionally is bad.
That's not a good thing.
No.
And the 56% is human performance deficiency. So what is the 44%? Is that like not the hospital didn't sterilize the equipment or something like that?
Yeah, I don't know specifically how they classify this, but a lot of these are systems errors. Was a mistake was made, the wrong specimen gets used without somebody actually making a mistake. Something's labeled wrong by somebody else. I don't know.
Okay.
Different things, system errors, I think.
Okay.
Next up, changing gears, prevalence severity of sesame allergy in the United States. This is from the same group who we talked about their paper months ago about food allergies overall.
Right. In January, we talked about overall prevalence of food allergies in the U.S.
Mm-hmm. And now they're looking at sesame, and apparently sesame allergy is a hot new allergy. And basically, they used the NORC survey from the University of Chicago, 40,000 adults.
I think it's NORC.
NORC?
Yes.
Okay.
Because you don't want to say NORC because it sounds like an Orwellian surveillance organization.
Right. Okay. I guess so. So NORC, 40,000 adults and 38,000 children answered their survey. They use this algorithm because they're doing a survey, but just try to see if it's a convincing allergy. Because if you ask a lot of lay people about an allergy, all sorts of things that aren't allergies get listed. But they found that basically 0.5%, so 1 out of 200 people have a sesame allergy. A quarter of those are severe.
Okay.
Not surprisingly, 80% of these people have another allergy. Half of them are allergic to peanuts. And this is, to go back to the epidemiologic data they described last time, I looked it up, 11% of people have a food allergy overall, 3% shellfish, 2% milk, 2% peanut.
Mm-hmm.
So this is basically sesame is not known to be, or is not as popular, not as savvy as an allergy. Everyone knows about shellfish allergies, peanut
Right,
allergies.
it hasn't made it into the popular consciousness as much, although some manufacturers will list sesame products as a warning to consumers.
Mm-hmm.
So I think it's out there, and you kind of talk about cross-reactivity. My instincts are there are some kind of antigenic cross-reactivities with peanuts and other things, but I speculate on that.
Yeah. I mean, my biggest understanding of it from when I've looked into it, mostly for trying to figure out whether or not it can give people IV contrast for CTs, is that the best data we have is that people who have allergies and just are more likely to have other allergies.
Yeah, except that many people who have quote-unquote allergies don't have true allergies. They just have some kind of anecdotal idiosyncratic reaction that we never really know what it is.
Right.
And we talked about that on a broadcast some time ago.
Right, and that's why I like their schema where they're trying to deduce from people whether it's a convincing allergy or not.
Right. So I've heard of salami science. I think this might be sesame science, right? Because they reported overall prevalence allergies, and I'm wondering whether they're going to spin off papers for each of these individual.
That could be poppy seeds and then onion and then salt, and it'll be an everything bagel.
Exactly. Yeah, mishmash science, right? Okay. What do you have next?
A couple more people joining us. Alex Reardon, PDF, King Braylon 1, Lior Bibas. Welcome. And moving on to our next paper,
Yeah.
this one's a mouthful. So it's identifying smoking environments from images of daily life with deep learning. So this, I try to wrap my head around this.
I think I can wrap your head around it.
Okay, so they got 4,900 pictures
Yes.
that smokers took in Durham, North Carolina, and Pittsburgh between 2010 and 2016. Then tried to use deep learning to figure out which of the places that were there are more likely to be places that people smoke versus don't smoke. Is that about right?
Yeah, that's about right.
And
so I think the users themselves identify and take pictures with their devices of the places that trigger their impulse to smoke. And then they feed that to a central group of investigators or researchers or image database. And then they sick this kind of deep learning algorithm on those places to see whether they can be identified prospectively from the features in images provided by the smokers.
Yeah, and I think the idea eventually would be that if I'm a smoker and I'm trying to quit, and I'm going to say a new restaurant, that the deep learning algorithm app in my phone could then analyze the pictures that are like in the Yelp reviews or whatever, and say, hey, you know what? There's a lot of things here that make this high risk to trigger your smoking urges, so maybe don't go to this restaurant.
Exactly. It's kind of proactive AI-based smoking prevention is the idea. This is just kind of testing the concept that the machine can figure it out.
Yeah, it's interesting stuff. It's fascinating. Probably still a number of steps from clinical utility,
right?
In a meaningful way, but honestly, part of my shtick when I talk to smokers is in the ED is they're not kidding when they say cigarettes are really addictive. So any little thing that helps people who want to stop smoking is probably good.
Right, and there's a beautiful full color image of a park bench in this paper, which we don't often see in our journal.
Interesting. Yeah, sure is.
And we have one more paper, right?
The last one we got, so the global incidence of frailty and prefrailty among community-dwelling older adults. So this is a systematic review and meta-analysis of 46 different observational studies with a total of 120,000 robust or pre-frail people from 28 different countries. Basically put all that data together, found that 14% of them who live 3 years become frail within those 3 years, basically a 5-to-1 ratio.
And what was do you know the case definition for frailty used in this study?
I do not.
Okay.
Imagine there's like a Maslow frailty index or something like that.
Because it's kind of like a Chief Justice Potter Stewart definition. It's really hard to define it, but you know it when you see it. And so it seems to be a very discrete clinical concept that we all can recognize. Frail little old man, little old lady need extra care, extra attention, but it's really hard physiologically to kind of say what it is. So I'm interested in how they define it for purposes of estimating prevalence.
Yeah. So I'll say I don't remember what they did in the study. I didn't dig that deep. I will say we've got a great newly accredited geriatric emergency department as part of my department.
Really?
Yeah, it's fantastic. And part of one of the interventions we do is basically frailty screens on basically everybody. I think everybody over 65. Now it's nurse-driven frailty screens, so it's not even the specialized geriatric nurses.
So everyone who's 65 or older who enters your ED goes to this particular part?
No, so it's not geographic. It's a kind of virtual.
I see.
But we do special. We are accredited to give like specialized geriatric care. Some places do geographic geriatric EDs. It's kind of like observation care. You don't need to be in a specific location for it to happen. But now every single one of our patients over 65, nurse goes through whatever the frailty score is and says, "Oh, do you live with X? Do you have Y problems?" And is I don't know what the criteria are, and they'll flag the patients as basically at risk for being frail or not at risk for being frail. And oftentimes it can be helpful. If I've got say a 70-year-old patient who lives alone or lives with their spouse and has pneumonia, they're like, maybe they need to be in the hospital, maybe they don't need to be in the hospital. Could they do okay at home, especially if it's in a gray area, and if they're flagged as higher risk for frailty, it might be one other thing that would say tip my hands, or maybe this patient will benefit from being in the hospital, getting more adequate social work assessments, getting post-acute placement for rehab, skilled nursing, et cetera.
Right. It's kind of like case management in a way where the risk factor is age rather than asthma or heart failure, for example. If you assess their needs early on, I imagine, is the rationale in your institution, but you can tell me, you can kind of manage their both not only short-term disposition, but also their kind of longer-term care needs, and thereby making them healthier, delivering higher quality care, and reducing long-term costs.
Yep. Yeah. And it's one of those things where it's really not just, ideally we could reduce costs across the board and that by itself would be good. But this is a lot of thing where you think about it, there's a really big, important human side. And if I'm sending somebody, I have the opportunity to see people this one tiny slice in time. And this might be the thing where, hey, we're now recognizing a problem. And it's like some of the hip fracture data where, of people who fall and break their hips, 1 in 4 are dead in a year. This is,
Right.
Is this one individual injury, not just an injury, but a sign of a longer term decline? Who
Right.
falls, who breaks their bones when they fall, et cetera.
Right. And this process you're describing, I imagine, begins that continuity
Mhm.
process that provides the support
Yep.
for these patients to not be disconnected
Yep.
from the system or from support that can help them make their way through their acute event.
Yeah, and sometimes the intervention is just, oh, you know what? Why don't we get the social worker involved? Talk to family, talk to friends, figure out a better thing, not necessarily keep people in the hospital or pull that big giant lever.
We have a couple new people.
Yeah, we've got, I'm going to mispronounce these, I'm sorry, Aljabut and Young0909. So thanks for joining us right at the end of our broadcast. We are going to take next week off, but after that we will be back. It should be the following Tuesday at 2 p.m. Central.
I think so.
We're probably going to, it looks like we're changing our standard time to Tuesdays at 2 p.m. because Mondays seem to be more problematic, more holidays and things like that. So Tuesday, 2 p.m. Central, join us again in not next week, but the week after. Enjoy more of your summer. Follow us on all the social channels, Twitter, Facebook, LinkedIn, Pinterest.
Subscribe to our
Subscribe on
podcasts. Which comprises Editor-in-Chief Fred Rivera and Deputy Editor Steve Finn talking about what's in the latest issue, along with the author interviews from this live video broadcast. We release new material every Wednesday morning in Chicago time at 10 a.m. And every Friday morning at 10 a.m. So we're now a twice-a-week journal. Stay tuned. We'd love to be publishing more frequently, and I think we'll see you next time.
Yeah, and read these papers some more at JAMAnetworkopen.com.
JAMAnetworkopen.com. Visit us frequently, often, like they vote in Chicago, and we'll see you next time.
Take care.